Okay, hi everyone. Let's see, 2:02, so let's go ahead and get started. I'm Jeremy Kupsko. I'm a research informationist here at the Health Sciences Library and one of the organizers of the Rigor and Reproducibility Seminar Series, where we talk about topics related to data, rigor, reproducibility, and also AI. And this semester and this year, we're also co-sponsored by the new Center for AI Learning. And today, I'm happy to bring one of the AI-related talks. Today, we have Dr. Judy Gichoya from the Department of Radiology, and she'll be talking to us today about hidden in plain sight, harnessing AI's ability for population health from medical images. And I'll ask that we hold questions to the end, and I'll hand it over to Dr. Gichoya.
Thanks, Jeremy, for the invitation, and so great to be here. Yeah, so I thought that it's easier because sometimes when you talk about ethics and AI, it's just amorphous. At least that's how I feel. And I thought that it may be easier if we come around and use some use cases. So I'll go through a lot of things, but the good thing is that we are in the midst of scholars. So if something is of interest, maybe you can read a paper and feel free to reach out to me. Or if you have read something from a different section that you're like, oh, you should think about this. Okay, I need to sort of put my computer to do not disturb and quit Teams. And so I hope that you'll find this helpful, and yeah, and I'm looking forward to feedback and suggestions. So I chose this topic around hiding in plain sight because ultimately what I want to show you is that a picture is more than 1,000 words. We don't understand what that means, but with AI, I think it's really a tremendous potential, but a lot of work is required to be done. Here are my disclosures, nothing that's going to be biasing this talk. And so I thought that my approach was going to be to use some use cases where I just look at why would I say a picture is more than 1,000 words, and then intersect with this concept that we've seen that AI is lazy and it likes shortcuts. And this is one of the toughest areas, I think, to study today. And then come back and say, what does that mean for equity? And that's why I bring in the population health and what does that, it's this tension between promoting equity and minimizing bias. And that's how our discussion is going to be. So, I wasn't sure if people have seen anything in computer vision, so I thought I'd put in just some basic things because it sets the framework for what I'm going to discuss. This is usually, now, we don't just even show this, you just show, do you know ChatGPT? And then you start from there to explain what AI is. And so it's this concept that you can, you have your data and you have your answers, and the AI makes the rules, right? So in the past, when in the traditional programming paradigm, we would have the data and the rules, and then we get the answers. And so you usually split your data into a training, validation, and testing set. Validation is used interchangeably. In this case, it would be not the testing set is really the internal validation, but the validation is just you have to reward your model if it learns well, and you have to penalize it if it's making a mistake. And that's encoded in the gradient loss function. And after several iterations of your data, and you have to specify how fast that the model should go through your data, those are the learning rates, and those are the parameters that you put in. And that's how you end up with this, if you have your answers and you end up with these rules. Sorry, again, I don't know what's going on with my do not disturb. So with that in, sort of framework, I want to move to imaging data. So all images tend to end up being, put in between a number, between, if it's darker or white, it's assigned a number because that's how it's going to be loaded in the in the computer, right? So you can see sort of this is supposed to be a picture of a face, if you can believe it, and you can see some places are represented as black and white, and then this is the mathematical grid. And there are multiple areas, but some of the most common for medical imaging are these systems called convolutional neural network. That is, you almost look at this like trying to shine a torch on very specific pixels and learning the pattern. And then ultimately you come up with your last connected layer that you decide, I'm going to think that if you see this type of things, then this is pneumonia or non-pneumonia. And so, you start with pixels, you end up with your input layer, and you go through many, many hidden layers depending on the model you choose. And then your final thing, you decide, is this a dog, bird, or a cat? And so in imaging computer vision, you can only do 3 things, at least today. And now this week we see, GPT-4 released the multimodal AI. I think it's bringing interesting things, still hallucinating. And the first thing you can do is a classification task. And this is, you're just giving out a number, not a number, a number, just a probability, but you're not pointing to people to where the abnormality is. So in this case, where I'm hovering, there's a pneumothorax, which just means free air around your lung lining. And you just say, there's a pneumothorax, and the end user can decide what they want to do with it. Sometimes you can do a bounding box. You're not very precise. You just draw a box around the area of abnormality. And finally, you can use segmentation. So for all our tasks, you're either using a classification system, a segmentation task, or a detection system using a bounding box. So let's go into my use cases. The first thing, if I'm saying a picture is more than 1,000 words, then you have to ask, then are imaging only models better? And I'm going to go through a few cases. The first one is this work predicting COPD. COPD is a disease where you have obstruction of your airways, and then you end up having increased work of breathing. It causes changes in your chest X-ray. Some patients, if you're advanced, there's a grading system, you may have to use oxygen. And so this group, what they did is that they trained a model where they picked the imaging and they picked this test that's called the pulmonary function test. Had a little bit gone, not used during COVID, because you get this pipe and you blow as hard as you can, and it tells you the function of, your lung and how the air travels through your lung. And so they picked these two without putting any other labels and train an image model. And then they also pick the radiologist report and combine it with the pulmonary function test. And then they use the model to predict what is this value of the PFT, and also use this other one to do the same. And what they show, we do always have to resize the images to load them on the GPUs, which is our storage. And what they're just trying to show is that we don't see a big difference when we change, the original size of the images to what is seen by the model. And in these two curves, right? So in AI, we usually use these ROC curves, and they represent the true positive rate versus the false positive rate. And your perfect model would be somewhere here at the corner, and that would be saying this is a perfect model. And what you see is that they have this sort of like even the error rate and the standard deviations, and the image-only model is performing better for predicting the pulmonary function test and also the severity of disease. And when it makes a mistake, because this actually matters, if you say maybe this is a normal patient versus gold stage 1, 2, 3, or 4, it just lowers the level by 1. Now, obviously, everyone gets different treatment. For example, 4, you need to get more, but you can see that sort of like this is the image only model performs better. Why this matters is that in this case, you didn't even need to tell the radiologist to label for you your data. It's very expensive to get radiologist time. And so if you can find these proxies that you can use the labels in and get good results, then that's a big thing, because you can scale the types of AI that we do. Here's some different work, again, showing on chest X-rays. And what we do here is we predict 6 conditions from just chest X-ray. We say, does this patient have vascular disease? Do they have diabetes? Do they have arrhythmia? Are they obese? Do they have COPD? And do they have congestive heart failure? And what we see here is that, and these are sort of occlusion maps, and we train a convolutional neural network, and we see, when we look at medical imaging, sometimes the things that we see in terms of where the model is looking at, we use something called saliency maps. It's not very good. It doesn't really correlate to what we see. And, sometimes, it could be pointing out here, but you're like, well, this is a lung disease, so you should be somewhere within the lung, but this tend to be more persistent. And actually the model here surprisingly predicts well for these cardiac diseases. And then we do one more thing, we add the social deprivation index. And one of the things that is pretty interesting about this AI system, if they can see more, and maybe these pictures are some of your lived experiences, then if I had 3 parts of your body, maybe your knees are for very old, but your lungs, because you live in a different area, that's why you run 50 miles a day and your knees are aging faster, but your lungs live in a place that without pollution, your lungs are younger. And so we don't really understand what are the signals that we see on imaging, but if we did, then you can start to understand even the differences in the population. So for this work, we put in the social deprivation index. This is a marker of poverty, it tracks crime rates, high school dropouts, this level of income at a zip code level. And if you have a high SDI, you live in a deprived area, and if you have a low SDI, then you live in a privileged area. And we see now that we have performance, again, AUC values above 0.76. One thing that I have to tell you, for example, radiologists, unless you have a proxy for cardiac arrhythmias, which is just sort of like something, maybe a support device is being put on the image that tells you, oh, okay, maybe this patient has a heart disease. Some of these things you really cannot look at an image and make the diagnosis. So this is impressive. And we validated on a patient whose age has been modified, on a patient who's a self-reported Hispanic and Spanish speaking. And in medicine, language remains very difficult to document in the EMR, because you usually use these cards that are terrible at translation, and you can't just really take a good history. And this is a patient who was had diabetes, was that was not controlled, and they ended up having an echo ordered for them, but they didn't come for their follow-up. And the model was saying, look, there is a congestive heart failure code for this patient that is missing. The most important thing to take away is even absence of a code is a form of disparity, because maybe you're trying to figure out anyone with pneumonia, I'm going to send them home oxygen. But if you don't know who has pneumonia, then you cannot implement those downstream tasks. So if you've helped anyone with a systematic review with ICD codes, then I'm pretty sure you understand and have respect for this type of coding. There's a follow-up paper where we showed that you can predict type 2 diabetes from front to chest x-rays. Again, difficult to explain. One of the rigor for this was just looking at where the models was looking at, and it turns out it's mainly around the clavicle area, which is around this area that's green, and around the subxiphoid area, and really thinking probably it's looking at the fat distribution, but just a first step that's trying to say, hey, maybe this is someone you don't know that they have diabetes, but they had a chest x-ray for just some other different, then you could actually start to catch them and intervene on them early. This work is done by this amazing team, of researchers. And, when you have osteoarthritis, it's usually graded using this system called the Kellgren-Lawrence score. It was really developed and validated for white male patients. And there's a lot of pain disparities across different racial groups. And what these researchers do is they say, what if, just like the pulmonary function test, we don't listen to what the radiologist says that this is the severity of their knee pain? What if we said, I'm going to listen to the patient and use the pain score to label the severity of disease? And what they show is that this algorithmic prediction score actually narrows the disparity between race, income, and education, but developing a new scoring system that is listening to patient, not relying on what the radiologist says, and improves the patients who are eligible for surgery. And this type of work that shows the downstream impact, to me, is one of the most impactful, because you can actually change. It's not just you're doing AI to publish a paper, but you can actually translate this type of outcome to patient care. And because if you need surgery, then you need insurance to cover it. And if you improve the number of eligible patients, then what happens is that they're not immobile. And then because if you don't take care of them, they become immobile, they add weight because they're not moving, and they're depressed because they're always in pain, then they truly, even if they did not start being ineligible for surgery, they end up being, now completely cannot have surgery because of, risk factors or clinical profile. And so the surprising thing about this work, though, is that we show again, and I'm going to show you at the end about my own work, that this model still, even if they narrow the gaps, is that they learn confounders. They do learn the sex of the patient, they learn the age of the patient, they learn the race of the patient. And so in this type of image-based models, we have to say, is the performance truly due to underlying disease that the model learns, or it's being using a confounder or a proxy that makes it make these predictions, which then becomes something that can be useful, which is really dangerous. So if you're above 40 years or you have a strong family of breast cancer, then you've had one of the mammograms, and you may know your breast density. Nancy Capello really changed how we take care of, we do screening mammography. Here you can see the breast is, you don't see as much white, and this is just the amount of breast density tissue. And she had been very faithful about getting her annual mammograms, and then, felt a lump 6 weeks, I believe, after, showing up for her annual mammogram, a screening test, went to the doctor, was diagnosed with stage 3 breast cancer, devastated. And this is because she had dense breast, and this type of breast hides a lot. If you were to look at the AI, sort of like the try to figure out a lesion on this. And so it's not unsurprising that we see quite a lot of work to try and say, could you tell us the risk of breast cancer? Now, even if I put these bounding boxes here, this is not how this model specifically works. It just takes these 4 images and codes them, and this means translates them to zeros and ones, aggregates these results. And if you have a risk factor, it's going to use it. If you don't, it's still going to give you a risk factor of breast cancer. And these are some of the 4 clinical systems that are currently used, including the Gale, the Taracruzic. They don't perform very well. You need to know a lot of history. For example, in my own family history, I may not really know if my great-grandmother had breast cancer. In Africa, my parents also even don't probably still have access to screening mammography. But this model, the Mirai, can use that or can just use the image alone. And we start to see, again, better performance, even for Black patients. This is just overall general performance for these clinical models without even looking at subgroup performance. So again, showing there's something about this imaging, they can tell us more, but I will show you why the but is in future. This work came from UCSF, where they look at chest x-rays and say, hey, predict healthcare costs at 1, 3, and 5 years. And they train these 4 models. One of their image-based model is actually the X one, this green model. These other ones are really some of their clinical model. And some of the things they use is zip code, income, those variables. If you hear that you're training a model like that, you should be really concerned because those, like I showed you, the social deprivation index, those zip code levels encode a lot of information that is really a poor proxy unless you're trying to promote disparities. But what happens is that what's surprising, and that was my big takeaway from this work, is that the image on a model performs as well. It's almost like it's encoding this income zip code, even if it doesn't have that information. And so they show, for example, this patient is going to spend more healthcare costs, and this patient is going to have lowest healthcare costs. This is a young x-ray. This is someone with a chest spot, tells me that they have cancer. They require a lot of contact with the healthcare system. And these are the falsely predicted ones. And really, when I look at this image, I see some calcium, the shoulders look old, and the aorta looks ectatic. So I would say that this is an older patient, but the model still cannot, we don't have explainability tools that are able to interact with us to figure out why is it looking at this that way. This is an area I'm very, very interested in. These images are generated using AI. It's this concept that as a physician, you can go to a room and say, oh, wow, this patient looks older than I thought. And, you try not to look surprised or looks younger than you thought. And this group used chest x-rays again to predict this chest x-ray age. And they show the patients where the chest x-ray age is younger than their is older than their chronologic age. Those patients died young. And the ones who are aging slower, their chest x-ray age says they're younger than their chronologic age, were alive at the end of follow-up. Again, this is just recently published work from a Japanese team, which is trying to say, if you look at this progression of different ages, where is the model looking at? And it looks around the mediastinum here, which tells us a lot because that's where the aorta is, and and really that's what the model is looking at. But what they do is that to say, if I use the age of the chest X-ray age of patients who have no diagnosis, have no all these comorbidities, what can you tell me is the odds ratio of having a disease? And you can see some of the higher diseases, which are some are even surprising. For example, liver cirrhosis, because it's not really a primary lung disease, but they can start to see some of these trends. And so again, I said a picture is worth 1,000 words. And the reason why I say this is because of my work that really set me down on this pathway where I demonstrated that AI can tell you the self-reported race of patients. And, the race is really, in this case, defined as a social and legal construct. I love this chart. It's wordy, but it's essentially showing you that we have been called different things based on when you are alive and what the census decided to call us. And so the fact that you can encode something that is a social and legal construct on an image is really surprising. And we showed that across multiple data sets that chest X-ray, as librarians, you're going to be more involved in helping us to curate and think about how to organize data and make data machine ready if you're not already doing that. And these are chest X-ray data sets. These are different ones for chest CTs, digital hand radiograph and breast mammograms and the cervical spine. And we showed that for the AUC values for chest X-ray is above 0.96. And we see that this performance holds on external validation. If you've had several speakers, then external validation is very difficult. You have to retrain the model, not this model. It works well, again, out of the box. And then we see that it's not, we thought that maybe it's the specific architecture. There's new work that is showing the specific architecture can be a cause of bias and across different data set types. I show these models to really focus you to look at this paper that shows that some of the saliency maps are not very reliable, and that we see this, that this is what the model is looking at. We try to look at multiple projections, did not help us. But even if they're unreliable, we know that at least what activates the neurons is around where the hottest area is. And so for the next few slides, I'm going to show you a couple of image manipulations. And all I want you to remember is that the best performing model is in the 0.93, 0.94, 95, 96. And then the radiologist would perform around 0.5, 0.55. And then you just have to look at what then this change is making the model perform. So in this case, when we block this area, the masked model drops slightly, but it's way better than radiology. So telling us that there is some other signal that the model looks at around and says, I think this is a Black patient. We pick patches and remove the patch, and sometimes we just use that patch for prediction. When we use the single patch for prediction, it's essentially trying to say, yes, I can still tell you what the risk of the patient is from a patch. And the other one is when we block, the biggest drop we see is in around this area, which is just above the stomach. And that can really vary when it comes to medical imaging. We segment the lungs and just look at the lungs only and the soft tissues. And you can see that it's not that you can see the lung, well, we see the lung performance is lower. We don't say that it's only the soft tissues that the model are relying on. We add noise and make the images blurred. And you can see that it's still, we see quite a big drop, but it's still not in the performance of the radiologist. And then we say, well, maybe what happens, maybe it's the processing, and maybe if we use pictures of those pictures, that signal would be lost. So we use this data set, which is a picture of a picture. And this is really done for places like back home in Kenya, where people may send you pictures through WhatsApp to interpret them. And this was done as a way to see, does the quality change? So this is the same image. And when we use the picture of a picture, the performance drops, but it's still way better than radiologists. We then start to downscale the images. So this is a 4x4 image, and you see the performance is around 0.6. And what really was surprising is that when you start to modify the chest X-ray by applying low pass and high pass filters, which shows either the gross textural things or the fine textural changes. And in this image here, where it's a high pass filter, you can think about this if you have TikTok or your children or your friends, where you put in these filters that allow you to look like a cartoon or something else. You do the same to the chest x-rays. And here, where we have high-pass filters, then the performance for the worst performing group, which is tell you who's the white patient, is around 0.86. How can you still have this type of signal on this image that is barely perceptible as a, as a medical image? We start to say maybe we are biased, and we know we are, but we just scan patients in the specific hospital and manufacture equipment, and then but we pick up those type of models, train it, and then do external validation. We don't see a difference. And then to calibrate some of these images, we usually use these phantoms. I was very grateful to the physicists who allowed me to borrow the phantom and scan it. And we get images, but this is the same phantom. This is not a real human, this is not a person. It just has body parts that allow people, the physicists, to calibrate like the CT scan. And when it takes this whole section, sometimes it's think the patient is black, and then half of the time it's think the patient is white. You'd expect that if it's random, that it would be around 0.5. We started to say, well, maybe our black patients are sicker. So why don't we look at breast density, age, and combine these things, distribution, look at people who have normal versus abnormal chest x-rays, remove density, look at, is it performing better for older patients versus young patients, or male or female? And we do not find the reason for this. So after many, many months and a lot of work, we showed that these models can tell the self-reported risk of patients across multiple modalities. I hope by just walking through how we evaluated this work, it shows you how difficult it is to do, because there's no real one way prescribed way of doing, evaluations of AI. And as all the possible confounders, we could think the shortcuts, we couldn't really find what this was, and we could not understand why. So remember the cases that I started off saying, from my chest x-ray, you could say Judy is black, she's female. You can calculate my age and say I'm 60 years, but my chest x-ray age could be predicted to be 78 years. You could say I live in a deprived area because you can get my social deprivation index, my ICD codes, I have COPD and heart failure. In the next 3 years, I'm going to spend 15,000. Represents tremendous opportunity for us to understand what these models are looking at, even if we don't understand why. And that's why we can never harness this in the real world setting. And so I talked about the use cases, and I'm going to talk to a little bit about shortcuts, because it's really important for you to understand this. And I'm going to use just this one case around COVID. So this group, I thought, first of all, this is amazing science in the public domain. And when we hit off with the pandemic, there were not enough data sets. And so this habit of how we curate data sets is super important. And so this first data set, what they said is, well, if we say that the first case of COVID, even if you went back, was at this time, if you had maybe a chest x-ray for 2016, should not have COVID-19 variant. And so people started, making this COVID-19 negative data sets from old data sets or pediatric data sets, and then positive from, the patients who tested RT-PCR positive. And what they show is that this model performs very well. You can see the red gap here, but when you send it that external validation that I showed for the, for the self-reported risk performs well, it really drops. And then when they even pick another data set that's different, they show that the same pattern is observed. Then they did two things. They looked at the saliency maps, which is those hot areas to see where the model is looking at, and then started to use generative models, which can say, hey, why don't you make a COVID positive chest x-ray to be COVID negative, and the other way around. And they show that these models really still rely on these markers. The models are lazy. They love to learn pixels. So like these labels here, when it comes to developing data sets, are very important. They tell you that this is the left side of the patient. They can vary across different institutions. I can tell you within Emory, we've seen, I have a sample of around 16 just different L markers and their signal intensity, and the model can just learn that and not learn any underlying disease. And these changes persist when they transform using the generative networks and look at the swap labels, where you start to see, oh, the model is starting to look at, like this was the R here, now it's been moved, and the model now is still moving and just following that. One other thing that this other show is that when you remove one shortcut, the model just picks another shortcut. It's not going to work as well. And this, I want you to remember the first place where I framed it as how you have your answers, you have your data, and you penalize when you learn something wrong, and you penalize when you learn something right. And so then they start to change the last layer. This is actually a pretty common habit now, and say, well, what do you predict the projection of the chest x-ray? Is this, and what's also the patient's sex? And you can see now you start to find this perfect, prediction, and it also persists on the external validation. And the reason why I'm showing you this is showing you, hey, if I can tell you that the model can tell this social, sometimes biologic, non-biologic findings on chest x-ray, and I, as a radiologist, cannot tell you why the model is looking at, but at the same time, it's also learning these other things, then how can we really evaluate these models to be fair? And how do we understand when it's a biologic and non-biologic signal? Because, for example, age is important for chronic diseases, but really with most of the, like review of the literature and are again looking at health equity and social justice issues in healthcare, then we know there's no difference in some of the diseases in terms of, risk distribution. And so when it comes to evaluating and thinking if an algorithm is fair, it's a very, very challenging thing. I think the best example that I have had is this cookie, how we split a cookie. If I split a cookie with Jeremy, we could say, well, Jeremy, this is it. Or maybe he's not as hungry and didn't really want half of the cookie. The models we use today, you have to fit wherever your definition of fairness to a mathematical function. And so it loses this construct. And the reason why we have these AI generated images of children is that maybe I'm going to eat a little bit of half of the cookie if I can choose the first TV show that we're going to watch. And so it's these negotiations that we think about them to be fair in this social explanation of fairness that are lost when it comes to mathematical thinking. And so we have a lot of trees that try to tell you, are you going to be fair to the group? You can think about a population health that way. Or are you going to be fair to Judy, who, if I have Medicare insurance or a private insurance, I may be more privileged than someone else who has a different type of insurance. And so it's this intersectionality that makes it difficult for us to determine what's the perfect model. And even if we're seeing quite a lot of toolkits that are being developed to detect and mitigate, it's still this mathematical function types of bias evaluation. I want to end by looking at what we have always thought about bias in the AI development pipeline. This is the AI system. You correct the data, you then choose your model, then you validate. And this is a paper that the Midrick Bias Working Group published, showing you could have bias at the data collection, you could look at model development, you could look at deployment, and it again showing this intersectionality, but there's no real one toolkit that helps you think about this. And so it has to be a system approach, looking at diverse data sets and also having diverse people on the team who bring a different perspective. I have really benefited from social scientists who are very big on, understanding even some of the anthropological changes. When we look at data set labels, then we can look at some of the changes that can have errors. Today, I mentioned it's very expensive to label data sets. And in this case, you can see that we use natural language processing to try and extract the labels. I can tell you, a chest x-ray data set at Emory, that's been quite an adventure. And what it can happen is that some of the labels are this concept of hidden certification. So here it's just like a COPD patient with expanded lungs, but this is a patient with injury and they just have free air. And all these are labeled as emphysema. The AI cannot, the labeler doesn't make this distinguishment. And so hidden certification is a common pitfall for people who are validating models and where they fail, because you cannot really there's no real way of understanding which are the small subclasses in data sets that the model is not working well on. And these are some of the further examples where they show, for example, if you have a pneumothorax model, which is free around the lung, they're all AUCs. This one, blue, 0.87. When you use the confounder, the shortcut of a chest tube, the AUC jumps to 0.94. But when you remove it, the AUC drops. But it turns out the most important thing for clinical care is to figure out which are these patients who have pneumothorax without a chest drain, and then work on this because they are the ones who need an intervention. These patients where the model is performing well have already received their treatment. Another thing that I kind of mentioned a little bit is this, mix and match of data sets. We've seen quite a lot. I'm not going to spend too much time on that. And we see that they actually, how you augment your data has a difference in terms of performance. So be careful. This is recent work that is showing that even just the choice of the model that you choose can have an impact on performance. These are just looking at people who are segmenting and using these 4 types of model, and they show that they have a different performance for different risk groups. This is, and we had this group present to our AI bias working group, and they said it's probably how some people, some hospitals, contour organs. But you really, when you're looking at the image, you wouldn't even really know that this patient is black or white. You can know that they're male or female, but it's really bizarre at how sort of these models fail. And so, in conclusion, I hope that I give you a glimpse of some of what I think is one of the biggest promising areas for AI to look at medical images and their AI performance. I walked you through how I looked at such a case and why I started off in this type of research, showing that it's actually pretty challenging to study this, especially in the context of shortcuts, when we don't know what are biologic signals, what's non-biologic. How do you validate something like race or insurance that I really cannot know what to tell you on a chest X-ray that this insurance belongs to a black or white patient. I walked through this inconsistent definition of fairness and why that is challenging, even as we start to think about how to deploy or validate these models in the real world setting. And I hope that I've given you an impetus to think about how we think about data set and the whole AI development pipeline using some examples. And so if you are ever a consultant or trying to help someone, you will have a frame of reference. Again, thank you so much for inviting me to be a speaker today in your seminar series. Please, reach out to me if you have any concerns. We held the first AI bias datathon this year in Emory. It was well attended. And I hope next year, if this is an area you're passionate about, you will join us. Thank you so much.
Thank you, Dr. Gichoya. If you have a question for Dr. Gichoya, you can put it into the chat or feel free to unmute and ask yourself. So you did mention that some of these algorithms aren't fit to be deployed medically, but are there other, I instantly think of insurance, who would be interested in knowing potential costs and lifespans where they may not care so much that they don't know how it works as long as it saves them money and deploy it.
Yeah, but it's not good for me and you, right?
Correct.
That's being profiled like that. But yes, we're seeing startups spinning off this way and starting to use the same algorithms to tell us better. If you need life insurance, you usually have to send someone to come to your house and do all those things to do your evaluation. It's very, very challenging. And if they can use this, they're going to buy your chest X-rays and extract this type of information. But we do need to do more work to understand, is it something that the AI is being pulled at, or is it real? And if it's real, how do we make it benefit everyone, not just the person who we are paying money to?
Okay, Brian, you had your hand raised. You can ask
Hi,
your question.
Dr. Gichoya. Oh, thank you, Jeremy. Thank you for this seminar. It was really great. I actually lead a group meeting for statisticians here at the CDC, and I canceled and told everybody maybe we should go to the seminar. And I'm really glad we did. So this was really awesome. there's a lot of potential reactions to like potential bad uses of this, or of these ideas and technology. I can see how these could be misused, but I'll keep it to maybe a simple or more practical question. So I have mixed race kids, and I mean, I'm wondering if has there been any study of mixed race people?
This is a great question. One, also, it's very in Atlanta, you cannot figure out who's mixed race. I don't know, hopefully your kids haven't been sick, but if you've had to go to the doctor, we either guesstimate what your children are, or you select other. And so this is also a fault in terms of how data are collected and how we extract ground truth. And the reality for this, Brian, I would really see it in relabeling data. For example, if the CDC had some imaging or just some data that they haven't really labeled, or it's just another look and another tool, more than trying to predict race, in my opinion, because this is a social construct, and it's really while that's a really a known limitation, and one of my wish list is to just work as a receptionist for a week and just see how people write who you are and how you're documented, because that label itself is troublesome. But what still brings rigor to this work is that we found that when other people take the model, go to Indiana, go to a completely different place, not even as many Black patients as Atlanta, it works very well. And so that's the bizarre part. Like, how can we have this almost systemic way of documenting people that is reproducible without even fine-tuning or retraining across on this? Really, it's actually bizarre. And you should always look at this type of work and say, wow, I don't believe it, and then move from there so that we can do the rigor that's required.
Well, so, I mean, that's exactly the reaction I had. But that's what good science is, right? When it's not when you say, oh, wow, you have this eureka moment. It's when you say, wow, that almost doesn't make any sense. So I congratulate you on finding this and investigating it and so on. Thank you very much.
Okay, I see Monica with her hand up.
Hi, Dr. Gichoya. Hi, everyone. Thanks for sharing this with us, Dr. Gichoya. It's so much great information and a lot of awareness, even for people who are not, clinical practitioners or AI specialists. So I just wanted to piggyback a little bit on the question that Jeremy had, and reacting to some of what you said, like some of those algorithms are not ready to be deployed because we don't quite understand. What are some of the steps that would help bring those types of algorithms in the clinical practice that would still be safe? Like, how do we go past recognizing that there's an issue and things are not ready to things being ready, and what are some of the things that could be happening to help with that innovation?
So thanks, Monica, and thanks actually for helping me with my systematic review. But my view has changed a lot, and the example that made me realize that if you had asked me 3 years ago, should you deploy a biased algorithm, I would have been like, no, you should build the algorithm that works for everyone. It's as of today, it remains a very difficult task. And so one person asked me, you are a manager of a HIV clinic, you have to give pre-exposure prophylaxis. The uptake overall is terrible, okay? And once it's terrible, you have an AI algorithm that actually works for the males very well, improves your numbers, but it doesn't work for women. And he asked me, would you deploy this? And I said, absolutely. I didn't even think twice about it. And I said, I'll deploy it because one, pre-exposure prophylaxis prevents another partner. And that the uptake still saves another, at least 2 lives. The second thing, I would spend as much resources that were used to purchase and deploy this AI to figure out why the women have poor adherence. So it's this world where we live in AI in our bubble, thinking that the way to deploy this is outside, quality initiatives, this expertise that exists in the healthcare system that allows us to understand, okay, we are tracking this, it doesn't work. But if we say we're waiting for the perfect algorithm, we'll never get there. Like, and then even if you brought all AI experts to debate what's a fair algorithm, I could say, well, it's fair for me as a maybe a Black woman who's on Medicare versus a Black woman who's on Medicaid, or Black woman who's uninsured, white transgender, just look at that intersectionality. We cannot even come down to say, how are you in these intersections? And we do not have that type of data.
Thank you.
I have one quick question. Thank you, Dr. Judy, for the session. It was really amazing. My question is about, in the initial slides, you mentioned that it's not possible for radiologists to manually label each of the input that we get. So in case, if we, hypothetically speaking, we do get some radiologists who are ready to spend their time, how much data do you think we should manually label in order to compare our AI model?
Yeah, that's a hard question, right? As much as you can is really always the answer. And it's not because they're not impossible, they're expensive, right? We don't have enough radiologists to just take care of you when you're in the hospital. So let alone now pick up AI things. That's why we use proxies. But there is new work on embeddings, and I encourage, hopefully one of the future speakers is going to talk about this new novel data set, synthetic data embeddings. And those data sets are showing that with as few as 45 images, you can have good performance. They are still encoding the same type of information, the race, the sex, the insurance across the data sets, but they're showing that maybe you don't need as much quality data. And I truly do believe, like embeddings, we've been doing some work on this, are going to change how we do AI in the next 2-3 years. Unfortunately, right now, they're still done by the big companies. The one we used were from Google, so you don't understand the underlying data. But you don't need GPU, you can just use CPU. And, so it's pretty, I think it's going to change how we work, but our analysis still shows they still carry those same signals. And the thing about AI in terms of from a health equity perspective, even if you don't deploy it, maybe coming back to Monica and Jeremy, is that maybe it allows us to start to think about health equity. So you can use these explanations and AI as a way of hypothesis generation. So we built a model. It's still, it was one of our students, and this was predicting postpartum hemorrhage. And it turns out the best predictor, the best feature was weekend. You can do everything. The AI realized that on weekends, mothers bled more, were most likely going to have postpartum hemorrhage. And that told me it's something about the issue with staffing the hospitals. And so, it just really, if we started to turn this and say, how can I use this to inform me what patterns should I look at? I think that presents a tremendous opportunity that can even bring up, hypotheses and questions today that we haven't thought about, because you may not be able to generate this type of hypothesis unless you're looking at this type of massive data sets. And yes, from a statistics point, you want to say, what's your hypothesis? But how about using these same approaches to reverse engineer what could be the possible questions we are looking at? And so as much as you can, and good label data, but that still doesn't stop us from trying to use these other proxies to label the data sets.
Okay. Thank you very much.
There's a question from Modella, Professor Modella. Thanks for what additional modality would you recommend for screening Black patients for breast cancer who have dense breast? Is this covered? Yes. So based on that breast density rule, Nancy Coppello, she's passed away, rest in peace. She changed this legislation and demanded that every woman would have to know their breast density. So you'll get this notice, you can go back. People still try to use those clinical scoring systems. And you can also, people are trying to understand the MRIs and the roles of MRIs and like ultrasound, just a different modality. So evolving area, but even with the big successes of breast cancer survivorship, then we've seen that Black women and have not had as many gains. They still die younger with more aggressive disease. And I just want to put up just a plug for a project that is coming down the pipeline, showing you again the harnessing of this type of hidden signals. And it's if we can start to tell this chest X-ray age, maybe really Judy's 20 is not, sorry to call on you, Monica, is not Monica's 20. And so we can start to think about a personalized screening age just based on this imaging. And maybe you could start getting your 40, but if maybe your breasts are for a 20-year-old or understanding, better for precision race, but all these interesting things, like I said, you should look at them and say, I wonder why that works. And then try and bring your collective interest and love for science to figure it out. Okay, great, Jeremy. I think there are no more questions.
Okay.
I hope it was informative and helpful.
Yes. Thank you again for doing this. Let me put in the chat where we'll put the recording for this. And again, thanks everyone for coming out. And thank you, Dr. Gichoya, for doing this.
Thank you so much.
All right. Thanks, everyone.